This is a fantastic episode with pediatrician Dr. Emeka Obidi, where you are going to learn all that you need to know to help you get off to a great start with your newborn. Welcome to the All About Pregnancy and Birth podcast. I'm Dr. Nicole Calloway Rankins, a board-certified OBGYN who's been in practice for nearly 15 years. I've had the privilege of helping over 1,000 babies into this world, and I'm here to help you be calm, confident, and empowered to have a beautiful pregnancy and birth. Quick note, this podcast is for educational purposes only and is not a substitute for medical advice. Check out the full disclaimer at drnicolerankins.com/disclaimer. Now let's get to it. Hello there. Welcome to another episode of the podcast. This is episode number 204. Whether this is your first time tuning in or you are a returning listener, I am so glad that you are spending some of your time with me today. In today's episode, we have Dr. Emeka Obidi. He is a board-certified pediatrician who practices in Maryland, where he owns a multi-provider family practice. He's also CEO of Newborn Prep Academy, where he runs an online newborn preparation course that helps both new expectant moms as well as moms who have recently given birth understand how to care for their newborn baby and what to expect so that they can feel confident, empowered, and ultimately enjoy their babies. He obviously clearly loves his work. You will hear the joy for his work come through. And we take a deep dive into what happens with your newborn in the hospital and that first visit after you leave the hospital. So you are going to feel really ready right after your baby is born. So you are going to learn, what is the vitamin K shot for? What erythromycin eye ointment is for? What is the hepatitis B vaccine and why is it given at birth? You'll learn the types of exams and tests that are done in the hospital for your baby and why they are done, like the hearing test, testing for jaundice, testing for congenital heart disease. You'll learn what you can expect with weight loss after your baby is born. This is something that Dr. Obidi sees a lot of women get stressed about, and probably unnecessarily so. Like maybe folks are making too big of a deal of things. And then we also chat about how soon that first visit will be with the pediatrician after you leave the hospital. It's actually very soon. And then how you can make the most of that visit. I love some of the advice that he gives to make this visit really productive and make sure you get everything you need out of that visit to understand how to care for this newborn. We also chat about the role pediatricians play in screening for postpartum depression in moms. They actually check a lot longer than I thought. And then we end with the confident mom's mindset, which I really love. And I think you are going to love it too. Now, before we get into the episode, I have to tell you about an upcoming live class that I have coming up. It is on Monday, April 24th. And this class is all about VBAC. VBAC is vaginal birth after cesarean. And if you want to get calm, confident, and empowered for your VBAC, then come join me in this live class. The truth is that too many OB doctors are not telling the truth about VBAC. I don't think it's done with malicious intent. I think some of it comes from not being informed on up-to-date guidelines or having outdated practices. But some of it is straight lying, y'all. And some of the things that I hear are overstating the risk of uterine rupture, saying that you can't receive Pitocin or be induced if you're trying for a VBAC. And VBAC, again, is vaginal birth after cesarean. Saying that you can't try for a VBAC after 2 cesareans. Or not telling you that the real reason you can't try for a VBAC is because they don't support it, not a medical reason. So you're going to learn all of the lingo in the class, TOLAC versus VBAC, why VBAC calculators are trash, in my opinion. The most important thing you need to do if you want to try for a VBAC, things that increase success, things that decrease success, evidence-based recommendations, what a low intervention VBAC looks like. Great stuff in this class if you want to have a vaginal birth after having had a cesarean. You can register for the class at drnicolerankins.com/VBAC. And it's going to be on Monday, April 24th at 7 p.m. Eastern Standard Time live. All right. I cannot wait to see you there. Okay, let's get into the conversation with Dr. Obidi. So, Dr. Obidi, thank you so much for coming onto the podcast. I am so excited to talk about this topic today.
Well, thank you so much for having me, Dr. Rankins. I've been looking forward to chatting with you.
Yeah. So why don't you tell us about yourself, your work, and your family?
Sure. So I am a husband and father of three. My wife and I have two daughters, aged 19 and 15. Crazy how time flies. And
doesn't it, though?
A son who's 9 years old. Yes. And I'm a pediatrician. I practice out in Western Maryland. I run a family practice and also more recently have produced content online to help moms who are expecting or recently delivered understand what to expect from their newborns, how to care for them confidently so they can really truly enjoy their newborns. And that's been lots of fun to do as well. And that's under the auspices of Newborn Prep Academy.
Absolutely. Yeah. And we will link all of your things in the show notes and whatnot, but you should follow him. He produces great videos. His energy is lovely. It's easy to understand. So you should definitely go check it out. So let's talk about what training you went through to become a pediatrician. I always like to have experts tell what kind of training you went through.
Sure. So my medical school journey started in Nigeria, which is where I'm originally from.
Okay.
And it's a patterned after a European system, a British system. So med school is 6 years.
Oh.
And yes, it is. So you go right in from high school, right into med school. And it's a 6-year program.
Okay.
So that was interesting. It was fun. I actually wanted to be an ophthalmologist all through med school. Yes. We had a family friend who was an ophthalmologist and she let me come hang out with her during my vacation time. I'll see surgeries. I found the eyes so fascinating, beautiful. But then, so the British system, when you're done with med school, you get a provisional license to practice as a physician, but you have to do a 1-year internship where you do 3 months in OBGYN, 3 months in surgery, 3 months in internal medicine, and 3 months in pediatrics.
Okay.
And pediatrics was my last rotation. I just fell in love with pediatrics. Like I was just out of the blues. I wasn't expecting it at all.
Right.
I had such a wonderful time. And it was an under-resourced country, so it wasn't always a pretty sight, right? There are lots of kids who could have, had bad outcomes that didn't have to. But it was just such a rewarding 3 months. I just said, okay, that's it, pediatrics. Okay. I came over to the States and did all the licensing exams to get into residency. I had a gap year, so I did a master's in public health at Columbia University in New York, concentrating in maternal and child health. And that was a really fun year. Yeah. And did my residency in SUNY Downstate in Brooklyn, New York.
Okay.
Yeah.
All righty. And you've been in practice how long?
Practice for about 20 years now, 21 years. Okay. I did 1 year hospitalist work, pediatric hospitalist work in New York. And then I came out here to Western Maryland to this practice where I've practiced for like 18 years now.
Okay. All right. I love it.
Owned it for the last 9 years.
Yeah. So lots of experience.
Lots of experience.
Yes.
Lots of experience.
All right. So let's get into what happens in the hospital after your baby is born. I can tell you that obstetricians don't know anything about what happens. And people ask us, I'm like, we don't know. And people don't realize, once mom and baby are separate, then the pediatrician takes over for the baby, immediately. And the OB doesn't do anything anymore. So let's talk about those things that are going to happen in the hospital after the baby's born. First up is the vitamin K shot.
Yeah.
So what is that for?
Yeah. Well, I'm glad you mentioned this. I'm going to back up for a second because
please,
you're right. Moms, first of all, pregnancy in and of itself, I don't have to tell you, it's just a whole journey in and of itself, right? All kinds of crazy things going on with your body, hormones, the pain, the whatever, right? The baby, all kinds of worries. And then what I found is most times when moms are also thinking about the baby, they're thinking about the baby care and the, nursery and all those different things. And no one remembers about everything that's going to happen after the baby's born. So it's really great to talk about it because I think, and having been in the delivery room several times, it's been a while now since it's taken care of by the neonatologist at a hospital my local hospital. But from prior experience, there's just so much going on during delivery.
Sure.
And I think the baby just plops out, and then there's all this stuff going on with the baby, and half the time mom is not sure what's going on with the baby because they're whisked up to some other place, right? But when the baby is born, so typically you're just gonna make sure the baby is fine, and most babies are gonna be born and be okay, but some may need some little stimulation or some help to recover and transition. I think we're all getting better with trying to recognize that golden hour where we try and make sure that mom gets some skin to skin time with baby, and where we're trying to establish feeding as quickly as possible, especially if she's going to breastfeed and all of that. So all that's going on. And typically we'll get all that happening first, make sure baby is stable. But then then there are some treatments that baby gets, which are helpful and for particular reasons. So one is vitamin K you mentioned, and that's a vitamin K shot, an intramuscular shot that's given to the baby because so vitamin K is important for blood clotting, the blood clotting process. And babies are born with very low levels of vitamin K. And sometimes low enough to cause some significant, serious bleeding conditions where you can have bleeding into the brain and cause permanent brain damage, bleeding into the organs. And so to prevent that, one shot of vitamin K will prevent that. And that bleeding can actually occur up to 6 months after baby is born. So it's been shown that just that one shot, can prevent that from happening, since you're not able to predict what baby might have low enough levels of vitamin K to cause serious, significant bleeding. And since the effects of those bleeding can be quite damaging and long lasting, it's just safer to give all babies vitamin K injection at birth.
Gotcha. And why can't they get vitamin K in their diet?
So a number of reasons. One is you don't get high enough levels with oral vitamin K, and especially for newborns, because it's very variable how much vitamin K is actually absorbed in the intestinal tract for a newborn. For an older kid, an adult who has some bleeding issue and they need vitamin K, they're able to take that orally. But for newborns, you can't trust the levels you get. It's usually very low levels. The vitamin K you get in breast milk is usually very low and not enough to actually prevent vitamin K deficiency hemorrhages.
Gotcha. So oral vitamin K doesn't do the same thing, and breast milk isn't going to bring the levels up. Will formula, if people decide to formula feed,
it still doesn't
also the same?
No, still the same.
Okay. Yeah, that's one of those like weird things to me. Like, why are babies? Why are we born with low levels of vitamin K? Why? But I guess it is what it is.
You're just thankful for advances in medical care, right?
Yes.
There's so many conditions that advances have helped us be able to better navigate those.
Absolutely. And are there any side effects from the vitamin K?
Not really.
Okay.
Yeah.
Okay.
It's well tolerated. No side effects, universally given. And so, millions of doses have been given at this point. And I think we'll recognize any significant issues.
Sure. Okay. All right. Yeah. It's been given for decades.
Yes, decades. I think it was like 1960 something or so.
Yeah.
It's been a while.
Yep. So let's talk about the erythromycin I ointment.
Yes. So the erythromycin I ointment is given to prevent what's called ophthalmia neonatorium, which is basically just a pink eye in the newborn. So a conjunctivitis or eye infection in the newborn. And that, again, when you have an infection in the newborn eye, can also be significant also. And of course, can threaten eyesight, right? It could be from any bacteria. We're most concerned about bacteria, gonorrhea or chlamydia, obviously an sexually transmitted infection. And so those are sometimes screened for during pregnancy, but not always caught. And so that's just a simple, again, treatment that can prevent your baby from getting an eye infection that can be damaging to their eyesight. It's a simple ointment that just applied once right after birth.
Okay. So if this is one of the ones that I don't know. I've heard that it's not as effective as we think. Like, how effective is it at preventing infection?
Yeah. And, the truth is, it's effective, but nothing is 100%. And yes, there are some bacteria that may not be covered. I think where mom has been properly screened for a sexually transmitted infection, maybe it's less of an issue than where maybe that screening wasn't done for whatever reason.
Gotcha.
Maybe there was spotty prenatal care, right? But again, it's a simple application. It's a simple antibiotic ointment. There's really very minimal side effects, if any, some eye irritation, and millions of doses have been given at this point and really haven't resulted in any significant side effects that one worries about.
Sure.
But the point is taken, as with the number of things we do, none of it is 100%.
Yeah. And then also, sometimes I do think I wish we could kind of individualize things more, because if you're in a stable, I know we often in the medical profession tend to always think the worst in a way. But if you've been screened for sexually transmitted infections, especially in the third trimester, and it's negative, then if this is something that you feel like, it's definitely going to be less of an issue for sure.
That's very true.
And then what's the third thing that's going to happen?
Yes. So the third treatment that newborns typically get is a hepatitis B vaccine. And again, that just starts the process of getting a newborn vaccinated against hepatitis B. Now, that's another one where, one has to kind of maybe co-individualize. One of the reasons we do it in newborn period is, quite a percentage of individuals that have hepatitis B are unaware they have hepatitis B. So they don't even know they have the infection, right? And so your baby could potentially be exposed to people who have hepatitis B. Now, transmission of hepatitis B does involve blood and, can also be sexually transmitted. So it's not necessarily something that your newborn is going to get just because they were carried by someone who has hepatitis B, right? But again, you don't know what that exposure could look like. And so in the newborn period, you can start that process of getting them vaccinated or protected from hepatitis B infection. And again, it's one of the ones where I think that, and in my practice, I practice the same way. I have open conversations with parents and around vaccines as well. And where there is some concern, I'm open to listening and seeing what we can do to get baby there. But again, none of this is life-threatening per se. And so I think it's one of those things where you do provide some information and allow parents to make the best decision for their babies.
Yeah. My husband and I, neither one of our girls, we are very pro-vaccine, but neither one of them got Hep B vaccine in the hospital. And it was just because we were like, I don't know, we just sort of felt like they're, honestly, the pediatricians also were like, we can just do it in the office. Like, it's not a big deal.
I do the same thing also. Don't sweat it if you're worried about it, But I think it's one of the reasons we also do it in the newborn period while they're there. It's a captive audience, right? Because sometimes the majority of babies are going to make it into the office, but there are going to be some babies who slip through the cracks, never make it for whatever socioeconomic issues going on in the family. And so they will have at least gotten some protection before they're out in the world. So again, this is where, individualizing care can be really helpful, because if you have a very stable household and parents are, connected to a healthcare system or to, someone who's going to provide care afterwards, it's less of an issue that's not going to happen down the road should they choose to do so.
Sure. So if parents have some concerns about these or want to ask questions, then how should they approach this? Is this something they should ask even during pregnancy, or like how should they get all of their questions and concerns addressed?
Yeah, I think so. And one of the great things, a lot of pediatricians will still do a prenatal visit where they can come in and talk about whatever concerns they have, get to visit the pediatrician and see if it might be a good fit. So I think that's some place they can certainly get information, it's just the local pediatrician. And I know some information is provided at the hospital. Again, I think there's so much going on when a mom is in labor that I don't know how much she actually really takes this. Like, just tell me where to sign. Just sign wherever. Let's get this party on the road because, I need to get this baby out.
Yeah, exactly.
So I think where they're able to get information ahead of time and really think through this carefully, I think it'll be great.
Or this is something, for instance, that, and y'all, I'm not affiliated with his class or anything like that, but this is something that would be included in like a newborn
Absolutely.
prep class, or should be, that you could.
Absolutely should be.
Yeah.
Absolutely should be. And we may talk about this later on, but I do have a newborn preparation course that lays all of this out. But again, it's getting that information ahead of time before, so you can really think about it. And actually, we talk about informed consent. And for it to be informed consent, you have to be informed and be in the right mindset to actually digest information and consent to or not to, partake in something.
Absolutely. Absolutely. Okay. So those are the ones that are done fairly soon after birth. What other exams and tests are done in the hospital for babies?
Yeah, I think this is where it's really great that, we've advanced to the place we have in medical care. There are a number of other screenings that are done while the baby is still in the hospital, typically.
Sure.
One of them is a hearing screen. So that's a universal program. All babies get screened, get the hearing screen. And it's great because you can pick up babies who have a hearing deficit very early on, where you can actually intervene and make a significant difference in their outcome down the road.
Okay.
Hearing is very important to be able to develop speech. And so if the baby is not hearing properly and that's not caught early, that can interfere with speech and also maybe limit the options that they have in terms of being able to provide some support with their hearing.
Sure. How often do babies, I'm sorry, go ahead. It sounds like you were geared to answer my question. I was going to ask, how many babies have trouble with the hearing screen?
I was going to say most, the vast majority of babies actually will pass a hearing screen, have no issues. And actually of those, and a majority of babies who don't pass the hearing screen, I'm not quite sure what the exact numbers are now, but just from experience, majority of those babies who don't pass the initial screen, and they're usually screened twice at a hospital, they fail it. Each ear is screened. If either of them fail, they screen again a second time. If they still fail that screen, then they're referred to get a proper hearing screen at an audiologist's office down the road, a couple weeks down the road. But most of those babies end up passing that screen. It's usually due to just some amniotic fluid still in the canal interrupting or interfering with the test. And a few weeks down the road, that's cleared and they pass that screen. But of course, the whole reason for a universal screen, such as a hearing test screen that is very innocuous to the baby, doesn't, you're not, what's the right word right now? It's not intrusive.
Right.
You're able to catch those babies that truly do need that help. Yeah. And if it's not done universally, there's no way of knowing, catching those babies until it's too late, perhaps.
Sure. Okay. So the hearing screen is one. What else happens?
It's one, yes. And then the other is a newborn screen that's done. And that's a universal program. Every state, the state programs, every state is slightly different, but it contains a battery of tests that are done from just a few drops of blood that typically will be gotten just from pricking your baby's heel. And that's sent to a state lab where it's screened for a battery of or a list of disorders that typically are not easily recognizable at birth. But if you can recognize them or pick them up at birth, you can provide treatment or interventions that provide a significant improvement in outcome.
Sure.
So that may be picking up some metabolic disorders where you have to feed a certain kind of formula to prevent that from progressing. Or maybe where you can pick up a thyroid disorder where you can provide, thyroid hormone as a supplementation so it doesn't affect growth. So a number of those conditions, sickle cell disease, quite a long list of conditions that are screened for in the newborn screen. So that's one. And usually that's done 24 hours after the first feed, because part of the test is trying to see how your body metabolizes proteins and carbohydrates and fats. So it's done 24 hours after that first feed.
Gotcha.
And typically a second one is done 8 days to a month out to confirm the initial test to make sure nothing was missed. And that's usually done in the pediatrician's office. So that's a newborn screen. And then more recently, which is also, again, I think becoming universal now, is screening for congenital heart disease. It's a very simple screen. They typically will just hook up a pulse oximeter just to measure your oxygen levels. One in the upper extremity, like the hands, and one in the lower extremity on the same side, like the foot, and see if there's a difference in the oxygen levels. They should be really close together. If they're, past a certain cutoff point difference, then that cues you in that it may be a congenital issue,
Sure.
heart disease, where our blood is not circulating in the right way to provide oxygen equally around, both upper and lower extremities. So that's a very simple test. That's also done, a screen that's done at the hospital. And the last one is screening for jaundice.
Okay.
Right, which is the yellowing that you can see on the skin of the eye caused by bilirubin. And that's also one of those things also that moms are like, I don't know, what's jaundice? I know it's yellowing of the eye and blah,
Right.
blah, blah.
Right.
But simply, what jaundice is really simply is our old red blood cells get broken down by the body and gotten rid of while new ones are produced. And those old red blood cells, when they break down, one of the things they break down into is bilirubin, which is this substance that can cause a yellow tinge to the skin or to the eyes. And the reason we worry about it is because at very high levels, that can be damaging to the brain. And in newborns, all of us can't get rid of bilirubin the way it's initially produced or initially produced when the red blood cells are broken down. We have to convert it to a form we can get rid of in the pee and the poop. So your baby oftentimes doesn't have enough enzymes to convert all that bilirubin that's floating around in the system, and over the next few hours and days produces more enzymes to get rid of that jaundice. And so depending on how high those levels are, and if there are other issues, complicating matters, maybe some bleeding that may produce more red blood cells being broken down, producing more bilirubin.
Sure.
Those can get to really high levels. And so all newborns are now screened for jaundice before they leave the hospital, usually in the first 24 hours as well, to see if those levels are levels that are acceptable, or if they're levels we need to watch more carefully, or if they're really high levels where they need intervention right away.
Got it.
Yes, those are the 4 screens that you usually will have at most hospitals.
Okay. And then what are the interventions for elevated bilirubin?
So phototherapy is the main way that's taken care of, especially if it's not critically high, where you now have to do what's called an exchange blood transfusion, where you're taking blood out of the baby and putting fresh blood in. Those happen like when it's really critically high.
Right.
But most of the jaundice is caught before it gets there. And phototherapy is a way to take care of that. And so your baby is put under some lights, phototherapy lights that have a particular wavelength that do the same thing the enzymes do. So they break down that bilirubin into a form that the baby cannot get rid of in the pee and the poop.
Okay.
And so that usually is how you'll take care of that. And, we're also told, you could put a baby out in the sun, indirect sunlight. So it's indirect sunlight. You want them covered. You don't want them to get a sunburn.
Right.
But those usually, if the levels are really high, just indirect sunlight would not be concentrated enough light to take care of the jaundice.
Gotcha. The next thing to talk about, and I'm sure that this gets moms, parents really worried. What can they expect with their baby's weight after the baby is born?
Oh, I'm so glad you asked that, because that's one of those things. I just feel like there's so much. Caring for a newborn is just so exhausting. There's just so much going on. It's really tasking. And I feel there are all these small things that kind of eat at a mom's reserve, that if you can just clear them all, she can at least have more bandwidth to deal with the real stress of caring for a newborn. And one of them is this, because a lot of moms are really unprepared for the fact that their newborn is going to lose weight. And so almost every newborn is going to lose weight the first few days.
Okay.
And most moms are going to go immediately to the place of, oh my God, I'm not providing enough food for my baby. My breast milk is not enough. They're not taking the formula, whatever, right? And which is usually not the case in most cases. So newborns lose weight. And the reason is, it takes a few days for moms to ramp up breast milk production. You can imagine how uncomfortable it will be for a mom who's already uncomfortable in being pregnant, having to carry around breasts that are full of milk and gorged the whole time she's pregnant, right? Just, the nature understands that that's not going to be good. We'll probably just stop having babies. And so babies actually come with some extra on board, some extra calories on board to help them through that transition period. And they're actually allowed to lose, for most healthy babies, allowed to lose up to 10% of their birth weight.
Okay.
And usually by 7 to 10 days, they're back up to birth weight.
Got it.
And so they have a few extra calories to tie them through. It's beautiful how nature works, right? Their fat cells are a different kind of fat called brown fat that produces more energy. So
Okay.
it's them again, provides energy during those first several days and beyond. Mommy's breast milk, the initial few teaspoons of breast milk you can get from the breast called colostrum has lots of calories packed in it already, again, to tide a baby through that period. So just to say that babies will all lose weight, for moms not to worry when they're told the weight on day 2 and is less than what it was the day before. It's not because you're not feeding them well. It's not because of any of those things most times. It's just a normal physiological process of adjusting to a new world and getting, ready to feed baby.
Gotcha. So you don't need to, if you're breastfeeding and you want to breastfeed exclusively, then you don't necessarily need to start formula just because.
Yes, you don't necessarily need to start formula because they've lost weight a few separate days. And, that's where monitoring the baby closely can be helpful because we can tell, this is acceptable weight loss. We don't have to worry about it.
Sure.
We have time. And even when they get to 10%, I'm still able to look at a mom and see how breastfeeding is going, maybe observe the latch and see, I think things are okay here. I think we just need a few more days because some babies will get back to their birth weight at like 2 weeks past birth and still be okay. So I think, no rush, no need necessarily to rush immediately to formula if you want to exclusively breastfeed.
Okay. You seem to take a very I don't want to say lay back because you obviously take it seriously, but you also don't want to make people anxious about and get all worked up about the things.
I think because most times there's no reason to. Right? I mean, in the work you do, right? You see a mom who is in a critical condition and you can recognize her right away. And there's no let's take some time to get her to the emergency room. I mean, both our daughters were C-section, all our kids were C-section, but the first one obviously was the first time. And I had newfound respect for you, OB-GYNs, because even as a pediatrician, as a physician, I was shocked at how quickly we got to that OR.
Right.
How quickly that baby was out because, her heart rate was just dropping. And so there's no wasting time when it's warranted, right? When it's needed. But a lot of times the issues we face and we see, there's leeway to really think about it, and talk through it and see what can be done. And even where something needs to be done urgently, we don't need to get mom all flustered.
Sure. Absolutely. Yeah. You can convey the seriousness without being dramatic about it.
Exactly.
Yeah. Okay. So once baby leaves the hospital, I think this is another thing that people aren't prepared for. How soon will that first pediatrician's visit be?
That is true. So I would say, generally speaking, it's going to be that first week. Most times the first 2 to 3 days, sometimes even the very next day. So it really depends on what's going on with the baby. If you have a baby who's lost quite some weight and you're worried and you want to kind of just watch them carefully, it may be the very next day. Or another case would be a baby who had jaundice and was significant enough to either treat, or maybe it's sort of on the fence where you might or might not treat. You might want to see them the very next day to repeat those levels, make sure it's fine. So there's some instances where you want to see the baby right away, like the very next day. Most times it's going to be 2-3 days out to monitor their weight, see how they're doing. But it does take a few, usually within that first week, all babies should be seen.
Okay. Yeah. And then is there anything that you recommend parents do in order to make the most of that first visit and feel good at that first visit?
Yeah. A few simple things they could do. One I would say is, and this will start right after the baby is born, as those questions start to come up, open up a note app, on your phone or someplace and start to just put all those questions down.
Sure.
Because you're going to forget half of them when you come into the office.
And then you remember them right after you left. Yes.
Right after you leave in the parking lot. So you do want to sort of put all those questions down so you can ask them, when you are with a pediatrician or whoever's seeing the baby. You want to really, as much as I really want to encourage moms and dads to bring in that discharge paperwork that they're given at the hospital.
Okay.
Half the time it's forgotten at home.
Got it.
But has really important information for the pediatrician.
Okay.
It has the birth weight, which most moms and dads will remember, but also has a discharge weight, which is really important because then we can tell, okay, they were discharged 2 days ago. This was their weight. This is what it is today. we're still fine. We're still within whatever,
Got it.
right?
Okay.
Yeah, so that's really important. It might have that, bilirubin levels, if those were done. It might have other concerns that the pediatrician or whoever saw them at the hospital, was worried about or just wanted to highlight, so all that is on there. So I really want to encourage them to bring that discharge paperwork in with them. Make sure you know where you're going to for the office visit and give yourself time. Because typically there's a lot of paperwork to do, and you want to give yourself time. And you have
you got to pack up all the
who's
stuff.
probably going to have a blowout right as you're walking out the door, and you have to go back in and change them. All that drama. So give yourself enough time to get there, and then just dress them in something simple, because you're going to be stripping them down to their diaper. So no fancy clothes, because it's all going to come off, and they're not always the easiest of clothes to manipulate in a newborn, especially for first-time parents. They're really afraid they're going to break the baby.
Right.
So
just keep it simple.
Keep it simple.
Yeah.
Keep it simple. Those are a few maybe helpful things that I will say. Something else I found very helpful, and I always tell parents this all the time, is your phone is like my best friend, because you can take pictures of things, you can take video recordings of things. My baby's breathing funny, just record it. It's much easier for me to see the recording and see if it's an issue or not than you trying to describe what it looked like or sounded like. The baby's poop looks funny. Just take a picture of it, right? And it just helps.
See, I love that, because some doctors are so like I don't want to, I don't need to see all that. That is great. Like, why would you not use
Makes it easier.
That? Yes. Yes. You can give people reassurance very quickly, or know that it's an issue very quickly. Yeah. So I love that. I love that. Okay. So one thing that I've seen more and more, and I think the American Academy of Pediatrics talks about this too. How do you play a role in screening for postpartum depression? Because you're almost always going to see moms sooner than we do.
Yeah. So all moms are screened at that first visit, and actually at every well child checkup up to 6 months. So
really?
It's at the first visit. It's at, the 1 month, 2 month, 4 month, 6 month visit. Right?
I did not know that. Okay.
It's the Edinburgh screening test that we use. And I will say this is one where I've started to pay more attention to, especially since I started to do some more work around educating moms around newborns, and talking more closely to moms, and realizing that a number of times, postpartum depression goes unrecognized by providers. Moms put on a brave face when they come in, and they, kind of pretend like everything is okay.
You're supposed to be happy because you had this new baby.
To be happy, you have a newborn baby. I mean, what's not to be happy about, right? And so there can be a lot of shame around postpartum depression, which unfortunately ends up like making it something that becomes difficult to provide help for.
Sure.
So I do really look carefully at those screens. And also, even when the screens don't seem to match what I'm seeing, go beyond and say, everything's okay.
Yes.
But it's important.
Gotcha.
To get to the screen.
And do you feel like you have resources that you know where to send people? Because that can be hard too.
That can be hard. That can be hard. I think that the primary care provider is one resource in terms of, especially if it's significant, because they can provide some support there. I try and talk to them about therapy, especially if there's also been a history of depression or anxiety already.
Right.
Sometimes it's helpful because they already have, a mental health provider they're connected to. And so encouraging them to really reach out if they need more help.
Sure.
But you're right. I think it's one of those things where maybe more help could be done.
Yeah.
I will tell you, I did a podcast interview months ago with a lady who lives in Sweden.
Okay.
And after the baby is born, every mom gets assigned a community health nurse who visits her for the first year after the baby is born. The first year, Dr. Frank.
Are you serious?
I'm not kidding you. I was like, what?
The first year?
And they have the lady's cell phone to text her. She's dropping in, several times the first month, and then monthly after that. Like, so there's such a, you really have someone that keeps an eye on you to make sure you're fine, help you to transition. Hopefully we'll get there sometime.
Oh my God. That's because they actually value people and families, whereas in the US, we don't the way we should. Oh my God. Okay.
So,
all right.
You're right.
Yeah. Okay. So the last thing I want to talk about is the confident mom's mindset. I love this, how you frame this. I think this is really important. So please share that with us.
Sure. I think we're just working with moms. And, in the last several years, I just realized, although I love all of pediatrics and still do, I particularly enjoy just taking care of new moms and newborns. And I've noticed that from just carefully observing the patients I've taken care of and worked with, which has been thousands of moms at this point, that the moms that seem to thrive the most in that initial period, I think just have a different mindset coming into it. And I've tried to sort of break this down into 3 kind of legs to the stool.
Right.
And one is, first of all, just recognizing that you're the best mom for your baby.
Yes.
It's a simple statement, but I think one that a mom really needs to sit with, right? You're the best mom for your baby. It's not the mom next door. It's not your sister. It's not your mother. It's you, right?
Yes.
Whether that baby came to you by natural birth or adoption, you are the best mom for your baby. Things have worked out where you get to care for this newborn, and you shouldn't feel like you're not enough or don't have enough to care for that baby. Which leads to the second, tenet that says that you've got what it takes to care for your baby. You have absolutely everything you have to take care of the baby. There might be information that you don't have, but then you have agency to go get that information, right? Yes. So no one's saying you have to know every single thing about a newborn, but where you need information, you can also get it also. You don't have to rely on somebody else to make all those decisions for you or to guide you. You get what you need.
Yes.
But knowing that you are more than enough to provide what that baby needs. And the third will be that you're in charge of a baby's care. And I truly feel, and this may be controversial, but I truly feel that your baby gets to actually adapt to you and not the other way around.
Listen.
Yeah.
Okay.
I really truly believe that. Some moms may throw things at me, but I say, what do you know? But I think that's where it works best, right? Because we're all different. I think I find that lots of moms that are super stressed are trying to conform to what they feel is the right way to care for this baby, right? The baby but it should be the other way around, right? So if you have the mom who is really very regimented and likes everything on a schedule, your baby actually falls in line very quickly. And they get into a schedule, we feed in, we feed out, because no mom is going to ignore that baby,
sure.
Right? Sure. The majority, right?
Sure.
So your baby can really adapt to your way of showing up in the world. If your mom who's just carefree and loves to do things, as they pop up, your baby will fall in line with also, and you'll feed on demand, and it'll be okay. I think that way you can really parent from a very authentic place and a more comfortable place. It's already a very stressful period,
right? And
trying to change yourself into somebody else for this newborn, I think, just sets you up for just a very horrible experience.
I'm going to have to agree with you. And it doesn't mean that you're not meeting the needs of your child
exactly.
or that you won't adjust if you need to sometimes, but you're starting from the place of you are coming into our family and this is how we as a family are going to make this work.
Exactly. You're so right. You will adapt to the baby's needs. That's just mother instinct, right?
Yes.
But you're not bending yourself into a pretzel.
Yes, or changing who you are to all of a sudden. Yeah, exactly. All right. So as we wrap up, what is one of them, these are questions I ask everyone. What is the most frustrating part of your work?
I think I just want to say it's when I just feel moms in the context of newborn care are just not getting information they need, where they also feel, and I try to create that environment as much as possible where a mom feels like she cannot ask the questions she wants to ask. I'm just supposed to keep quiet and just listen to whatever you say and not challenge any of that or ask any questions. I think it's just frustrating when there isn't that openness in that relationship between the parents and between a patient and a physician.
Sure. And then on the flip side, what's the most rewarding part of your work?
Oh, it's pediatrics. What's not to love? I get to see cute babies all day long, cute kids all day long. I get to, which is really rewarding because especially when I've done it as long as I have, to see kids grow and remember when they were born and now they're teenagers, now their voices are broken and they're young ladies. I'm like, where did time go?
Right.
I have so many patients now who are coming back with their own babies. I'm like, no, I'm not that old. it's rewarding. It's just
Yeah.
beautiful.
Isn't it just a great feeling when you love your work and you feel like you're in the place where you're exactly supposed to be?
Absolutely.
Yeah,
It
doing the
is.
work that you were put on this earth to do. Yeah,
Very much
yeah,
so.
yeah. So what is your favorite piece of advice that you would give to expectant moms or expectant parents?
Yeah, I think it'll go back to mindset. Just
Mhm.
saying, it really affects a lot of things we do. And I don't think we realize, just in a lot of personal development work over the last several years, realize how critical mindset is. And I think
Mhm.
in midst of getting all the other things ready with the nursery and the baby gear and diapers and what we're going to use, the cloth or not, and all that, taking time to really prepare your mind
Mhm.
and your emotions for what's about to happen.
Yep.
And because I think you just come at it, you just end up being a more centered person when your newborn arrives.
Sure.
So
Sure.
just not
Sure.
relegating it to something, some woo thing, but really taking time to think through it. How am I going to show up? Okay, this is going to be difficult. What are
Mhm.
my resources?
Mhm.
How am I going to be able to navigate this period? Just thinking through some of the things that end up just hitting you, like you're blindsided by if
Yeah.
you don't think
Yeah.
about it beforehand.
Yeah, I love that. I love that. And that's gonna set you up for, the journey of parenthood because the newborn period is just the start. And it really sets you up in life,
Yeah,
to
very,
manage things that
very much
happen for
so.
sure. Yeah, for sure. So where can people find you? What are all of the things you have to offer? Tell us all the things.
Sure, sure. One good place to just be newbornprepacademy.com. So it's newbornprepacademy.com. I have some free resources on there, how to choose the right pediatrician for your baby. I have a confident new mom guide that kind of goes through some of what we talked about
Mm-hmm.
today. And for those who really need more support and I think really want to prepare themselves for the newborn, I offer the newborn preparation course. It's a 4-module course that really just goes through all of this, the mindset, what your baby's poop is supposed to look like, what breastfeeding looks like, and formula feeding, and if you want to do both, how to do it successfully, and all the different things, how to take care of a circumcision and the umbilical cord, and all of that. It's really a very helpful course. I think prepares you for your newborn, and it can be found on social media, on Instagram at Dr. Obidi, so it's DROBIDI, or on Facebook at Dr. Emeka Obidi,
Awesome.
DREMEKA OBIDI.
Okay. Thank you so much. This was incredibly useful. I appreciate you coming on. This was great information.
Thank you so much for having me on, Dr. Nicole. It was really wonderful chatting with you today.
Wasn't that a great conversation? Can't you just hear the joy that he has in his work? I love it when I get to connect with people who are as excited about their work as I am. There's just such joy and pleasure in being able to do work that you so love. And he clearly loves his work and just gave some great information there. Now, after every episode when I have a guest on, I do something called Dr. Nicole's Notes, where I talk about my top takeaways from the conversation. Here are my Dr. Nicole's notes from my conversation with Dr. Obidi. Number one is understanding what's going to happen in the newborn period really should be a part of preparing for the postpartum period, and it should start in the 3rd trimester. We do not do a good enough job of helping people get prepared for having this new baby. And yes, people do registries and baby showers. And of course, all of those things are fun and necessary and rituals surround having a baby. But you also need to understand a bit about how to take care of this new person that you're going to have. And it doesn't have to be complicated or involved. It's just helpful to sort of know what to expect, just like childbirth education. So definitely start thinking about doing a newborn prep class somewhere in your 3rd trimester. Again, they don't have to be very extensive or long, but it just helps you to have a sense of what to expect when this new baby is coming. Okay, number 2. As I said in the episode, my husband and I actually declined the hepatitis B vaccine in the hospital for both of our children. Not that we're anti-vaccine. We're all vaccinated. Our children are vaccinated against all the things. But for us, it just felt like we don't understand why our child needs this right now when they are not at risk of being around anybody who has hepatitis B. And our girls are 13 and 15 now. And at the time, our pediatricians were like, this is no big deal. You can just get it done in the office. I think some pediatricians' attitudes have shifted and they may not be as flexible about it. That's sort of my gestalt just from hearing what people say online. I can't say that that's necessarily true. But for us, it just didn't feel, I don't know, just didn't feel like it was something that needed to be done right away. It got done at a later visit. And honestly, looking back, I would probably also decline the erythromycin eye ointment. It's really given to help reduce the risk of gonorrhea or chlamydia in the eye. And if you're confident that you don't have those things, then your baby's not going to get them. So I probably would have declined those as well. We had conversations with our pediatricians. And again, at the time, that was all fine. Now, I'm saying all this to say that I really wish in our system that we would take a more individualized approach in the context of population health. Like doing vaccines and doing things on a schedule is important in terms of population health. And when you look at things like syphilis, for instance, there's been a big increase in neonatal syphilis recently. That's a big population health problem. And some of that can be reduced by testing or screening for syphilis more consistently in the third trimester. Syphilis, by the way, would not be prevented by the eye ointment. The eye ointment is really for gonorrhea and chlamydia. And quite frankly, it doesn't work that well, to be honest with you. So I say all that to say is that I wish we would take a more individualized approach to the way we care for people and have conversations and be more trusting, I guess, that people are going to make decisions that work best for them. So that's just my 2 cents about making those sort of choices and decisions. This also filtered into when we did vaccines as they got older. It didn't feel right for us to do like 5 shots at once and that kind of thing. So we sort of spaced them out. So we kind of made our own schedule, which I know irritates the blank out of pediatricians, but we did what felt best for us. And you should do the same. Okay. Third thing is I just love that confidence mom's mindset. You really are the best mother for your child. I like to say that our children choose who their mothers are. And the combination of the sperm and egg that came together to make your child was right for you. You are the best mother for your child. So really believe that and internalize that. And I also really like the advice that yes, your children need to adapt to your life to some extent. You don't need to upend your whole existence because you suddenly have a child. All right. And that's not to say that things won't change or that you won't adjust things in your life in order to meet the needs of your child. Of course you will. But you should not upend your entire existence for your children. Your children need to fit to a large degree into your own life. I think that is very important and helps create a healthy, balanced family and environment. And that can look like different ways. Like, for example, if you traveled a lot before you had a baby, some people continue to travel after they have a baby. Just because they have a baby, that doesn't mean that they don't suddenly do the things that they used to enjoy. If you like to eat out, then people still continue to eat out after they have a baby. They just bring the baby with them or find a babysitter. So you certainly need to have children adapt to your life. That's really important in order to keep everybody happy. Okay, so there you have it. Do me a solid. Share this podcast with a friend. Sharing is caring, helps me reach and serve more pregnant folks, and I appreciate you doing that. Also, subscribe to the podcast wherever you're listening to me right now. It helps the show to grow. Leave a review in Apple Podcast. I love to hear what you think. You can also let me know what you think by DMing me on Instagram. I just love it when I get those messages, and I try to respond to as many as I can. When folks let me know what the podcast has done for them and how it has impacted them, it really just warms my heart and helps to keep me going on those days when things can get a little bit stressful. So that's DM me on Instagram at Dr. Nicole Rankins. And don't forget about the VBAC class. That's drnicolerankins.com/VBAC. That class will be Monday, April 24th, 7 p.m. live Eastern Standard Time. So if you are wanting to have a VBAC, do join me there. So that is it for this episode. Do come on back next week and remember that you deserve a beautiful pregnancy and birth.